I'm Tal Raviv, and I'm pleased to have with me Dr. Neeraj Desai here from Milan Eye Centers in Atlanta. And Dr. Desai, I want you to talk today a little bit about one of the Scheimpflug imagers we have, and that is the G4.
We began using the G4 in our practice a few months ago, and we have an existing Pentacam device in our practice as well, which is a Scheimpflug and a placebo-based imaging system. We incorporated the G4 because of its sort of unique characteristics with the dual Scheimpflug camera and the placebo-based system. As Dr. Koch has taught us in the recent past, that posterior corneal astigmatism is extremely important to consider for modern-day cataract surgery. And we have also incorporated femtosecond cataract surgery. So for us, a G4 device sort of completes the picture to get more accurate IOL calculations and more accurate assessment of the corneal profile.
Do you use the posterior corneal numbers to change your planning for toric lenses currently?
I do, and one of the biggest changes that we've made is I directly now use the ray-traced total corneal power, which is available on the G4, for my astigmatism numbers. I also use that number for my post-LASIK and post-RK patients. And I have seen very good results, although they're anecdotal and we haven't tabulated the results because it's quite a recent addition to our practice. But the patients do quite well, and I'm very happy with the numbers I'm seeing coming through.
When you say using it for LASIK, how do you mean?
The ray-traced total corneal power, and there are several variations of them incorporated into the G4, can be used directly as your K-powers for the IOL calculations that you perform. So I've been taking the K-powers and plugging them into the IOL master to derive more accurate powers.
That's very interesting. Do you still use an IOL calculator, and when you do you just plug in the total ray-traced corneal power into that?
I do. I still, in the first few cases, I wanted to compare the Ks between the G4 and the ASCRS calculator, as well as doing some back K methods. But I found that the G4 was the most painless and accurate way of getting the Ks.
In a post-refractive case?
In a post-refractive case, that's correct.
So just to repeat, in a post-refractive case, you're taking a direct measurement of the cornea with no prior history and using that right into your formula.
I am, and that's something that I'm doing. I'm not saying that you should do, but I found good results with this, and as we go on, we'll tabulate and refine our data and our technique.
So it sounds like the Galilei is something, the G4 is something most cataract surgeons need to use. We've all used it before for refractive screening. And tell me about a little bit the refractive component of it as far as keratoconus screening and other indices that it provides.
So the G4 has many software programs built into it, and the keratoconus profile is one of those. And we're not a very LASIK-heavy practice, so I don't see myself using very much of the keratoconus screening. However, for cataract surgery purposes, the total corneal power is what seems to be the case to use, and has really prevented us from refractive surprises that we used to have before. The G4 also helps. It seems to be a bit more efficient because of the unique iris. It's sort of an iris registration process where it captures and prevents decentration of the imaging. So it captures the iris, and then movement, mild to moderate movement, is neutralized because of that.
Thank you. Besides the obvious measurement we talked about, the total case, which I think is an improvement, is something we all want to get our hands around. Does this topography do other things like pupillometry or maybe surface analysis, dry eye, anything else?
It does. So it's a placebo-based as well, so it can give you surface data, and there are many programs built into it where you can access and look at different parameters. Dry eye is something that can certainly ruin your topography, as has been shown by many papers and talks. Dry eye can certainly cause pseudoastigmatism. But the G4's imaging has been consistent. We tend to take 2 or 3 scans, and we look at them, and we're not really using artificial tears anymore to lubricate the surface as much. We seem to get very quick and reliable measurements, and that are reproducible. So we're happy with what we're getting.
Well, thank you. It sounds like we're in the era of imaging the anterior ocular surface, whether it's the cornea all the way down to the lens, to help us achieve best outcomes, and the G4 seems to do a lot of that for us.